Hello friends, today we are going to discuss about body dysmorphic disorder, also called as body dysmorphophobia. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMHANS, Bangalore. In this video, I'll be discussing about body dysmorphic disorder, how to diagnose, what are the signs and symptoms of body dysmorphophobic disorder, prevalence, comorbidity, assessment, and treatment. Body dysmorphic disorder, as I mentioned, it is also called as body dysmorphophobia, is characterized by distressing or impairing preoccupation with slight or imagined defect in one's own physical appearance. BDD is commonly considered to be an obsessive-compulsive related spectrum disorder because it has the similarities with OCD of repeated thoughts and also compulsive act. Here, the obsession with regard to BDD is preoccupation with imagined defect, compulsions such as rechecking, camouflaging, ritualistic behavior of hiding the flawed defect or imagined defect, and also compulsive reassurance seeking. Let's understand what are the different diagnostic categories. How do they diagnose BDD, that is body dysmorphic disorder? ICD-11, International Classification of Disease 10 by WHO, has placed BDD under obsessive compulsive or related disorders. So BDD is there in OCD spectrum. In this regard, the diagnostic criteria as per ICD-11 starts with persistent preoccupation with one or more perceived defect. The specific word is perceived defect or flaws in appearance that are either unnoticeable or only slightly noticeable by others. That's very important. That is perceived defect or perceived flaw. Excessive self-consciousness, that is, they start thinking people are looking at them because they have a defect. So that excessive self-consciousness is very essential. Sensitive to criticism. They feel they are rejected because they have defect or flaw. Engaging in repetitive behavior such as repeatedly checking the mirror, excessive attempts to camouflage the perceived flaw by applying cosmetics, face cream, various other methods they will use, or alter that perceived defect in a ritualistic manner is also seen. Along with this, ICD-11 gives very importance for socio-occupational, academic and biological dysfunction should be there. However, ICD-11 further goes with insight specifier. It talks about BDD with good insight, BDD with absent insight. Another one is unspecified. What is this good insight? Willing to accept there is an alternative explanation for their experience or perceived flawed defect. However, with regard to absent insight, beliefs are true and they cannot accept any alternative way of thinking. But however, although ICD-11 talks about the insight into two categories, unfortunately, the insight does not go in this fashion because unfortunately, insight has not read ICD-11. The insight varies across population. Also, within the patient, it fluctuates. Whenever the patient has severe anxiety, maybe severe depression, in that moment, he believes that perceived defect is truth. But however, whenever the anxiety is low or the anxiety is not there or depression is not there, the belief system also may be less. That means the insight varies across population and within population also. That means it is a dynamic phenomena. It is not a static phenomena that one need to understand. But however, this insight also has been found to be very useful in OCD assessment and treatment. But here in BDD, let's see whether this insight plays a crucial role or not. Moving to DSM-5. What does body dysmorphic disorder is categorized here? Again, BDD is being placed under obsessive compulsive and related disorders. So let's see what are the important criteria they have placed. They have placed the first important criteria is preoccupation with one or more perceived defect or flaws in physical appearance that are not observable or appears slightly to others. Again, the first thing is preoccupation. Second one is at some point of time during the course of the disorder, the individual has performed repetitive behaviors or mental acts in response to the appearance of concern. That means here you would have done certain repetitive acts such as checking in the mirror, asking, comparing those flawed defect with others. So those kind of things, or else repetitive applying of cosmetics, or else fairness cream, or going for cosmetic surgery. This preoccupation causes clinically significant distress with regard to social, occupational, and other areas of life. The appearance of preoccupation is not better explained by fat or body weight or related to eating disorder. That you should know. That means BDD need to stand out separately away from the eating disorder. Although BDD and eating disorder may be a comorbidity may exist, but however, to make a separate individual independent BDD diagnosis, the eating disorder should not be there. However, the DSM-5 talks about specifier. The specifier has muscle dysmorphia. That means here, usually it occurs in male, where the person is more focused or preoccupied with the muscles. That is muscles around his body, muscles around his limbs, whether they are appropriate or they are small. Those kind of flawed defects will be observed with the good insight, with poor insight, or absent insight or delusional beliefs. Again here DSM-5 gives a specifier up to 4. Although again here the insight has been given more importance as a specifier in ICD-11 and also in DSM-5, with regard to medication, this insight may not play an important role. However, with regard to psychotherapy, the person who has insight will be very cooperative to do therapy, especially cognitive behavioral therapy. Let's understand what are the clinical features of BDD. The clinical features. The onset of body dysmorphic disorder is usually during adolescence, invariably before 18 years. 2/3 of the patients are commonly seen. The onset is before 18 years, but however, even in children, the BDD can be seen. Very rarely, the BDD is also seen in above 18 years, that is in 1/3. Most of the study talks about male to female affected are same, but however, there is a slightly increase in female predominance in the occurrence of BDD. It remains undetected for 10 to 15 years because many of the parents, patients, family members, relatives, friends, they think BDD is normal. At the age of adolescence, thinking about the looks may be normal, and many a time even the healthcare providers also believe it is a normal phenomena and they will grow out of it. Unfortunately, BDD doesn't go. They suffer a lot, and since the BDD occurs in the second decade of life, it will damage their career, their academics, their dreams, and also occupation. Hence, one need to be very, very careful when dealing with BDD, because BDD is very chronic and it is gradual in onset and it has a recurrent exacerbations and fluctuating course. Above all these things, BDD has very high suicidal rates. That means if you are thinking your child is suffering from BDD, or else his relatives or friends are suffering from BDD, please take action. They need to consult and seek help. Let's understand what are the other clinical features. The most important clinical feature is preoccupation or excessive concern or recurrent thoughts of perceived flaw or perceived defect in any parts of the body. Invariably, the preoccupation lasts for 3 to 8 hours. There are patients who think about this flawed defect up to 24 hours. Whenever they are awake, they think they are defective. Their face is abnormal. They look like monsters. What are the areas this preoccupation or concerns are common? The most common is skin. The skin is the largest organ in our body, where most of the patients think that skin is either defective, there is a scarring, there may be some skin marks, skin tags. They feel they look like monsters. There may be preoccupation with hairs, hair thinning, hair color, also fall of hairs. With regard to eyes, the patients may feel that their eyes are asymmetrical, they are not big, they are very small, they are ugly. Many of my patients are also had nose problem. That means the nose is not symmetrical, the nose is crooked, the nose is ugly. Some patients had teeth related issues. Crooked teeth, nobody likes my teeth, the teeth need to be reorganized. With regard to lips, some of the patients will come up and say they have a lips like buffalo, maybe cow, and I look very ugly with these lips. So those kinds of patients are very difficult to handle, but at the same time, they are very distressed. With regard to chin, there may be thinking that their chin is very big. Sometimes facial features like asymmetry of the face, they feel that right side of the face is smaller than the left side, or the face is completely crooked in nature. Some of the patients may also have the preoccupation with regard to breast, genitalia, maybe muscles, buttocks, thighs, and so forth. That means BDD can affect any part of the body. In a lifetime course of a BDD, the symptoms varies over a period of 2 to 7 in their life. That means the patient today he may have, there is a crooked nose feeling. Maybe after 2 to 3 years he may feel his face is abnormal. After 6 or 7 years down the line, he may feel his body basically the muscles are crooked. They are not in the right direction. And later he may develop even with regard to hairs. That means invariably a patient with BDD may develop 3 to 7 different types of BDD symptoms. And the commonest being the skin. The skin, as I mentioned, scarring, pallor, darkness, disfiguration, vascular marking. So various concerns have been raised. Facial features I had mentioned like symmetry, forehead is big, small, chin, nose, prominence of the malar eminence, lips, cheeks, with regard to size of the breast and penis. These are the commonest preoccupation, and these preoccupation are not normal. These preoccupation lasts for 3 to 8 hours and comes in their way of functioning. If he is a student, he is unable to focus on studies. And this will result in severe impairment in his functioning. Now let's look into the second important, repeated acts, which are time consuming and distressing behavior, such as checking mirrors. These patients spends 2 to 3 hours in front of the mirrors. Repeated grooming, applying excessive cosmetics, trying to camouflage the perceived defect by using fairness cream, maybe various other creams, applying various other herbal products, maybe wearing huge glasses, hats, wigs. Sometimes they will ask for reassurance, skin picking, and many of the patients will do self-surgeries. If they think there is a tag, they will try to remove by using blade, maybe pins, needles, knife, sharp instruments, and they create a big scar, which will further add to their suffering. Many a time, they hide their defects by wearing big glasses, scarves, covering heads with the hat, handkerchief, hands, keeping face down, not making eye contact, and various other methodology of camouflaging they start using. And they also have a repeated consultation with cosmetic surgeons, maybe dermatologist, skin, ENT surgeons. But however, to be clear, the body dysmorphic disorder, they need to have avoidance, avoiding public situation, social interaction, becoming self-conscious in social situation, feels that people are talking about them, people are looking at their flawed defect or perceived defect, and they feel they are being mocked at, and they will develop occupational dysfunction, unable to focus on work, and they will be constantly thinking that they are defective. They are unable to maintain relationship because of this BDD. BDD can be a chronic disorder and which leads to a severe disability and poor quality of life. Hence, it needs to be recognized early and treatment should be started early. BDD remains hidden for 10 to 15 years. Many people will seek help only in the second decade of life or in the third decade of life, when they have lost the precious academic life or else career life. Research have indicated that BDD has a poor quality of life, severe disability, high rates of psychiatric hospitalization, suicidal ideation, and completed suicide is very common in BDD. Let's understand the prevalence of BDD. How common is this body dysmorphic disorder? There was a study conducted in 2016. This was a systematic review and also meta-analysis of prevalence of BDD in various settings. This was conducted by VLA and his colleagues with regard to prevalence of BDD. The prevalence of BDD in the community was estimated, that is, in community studies, especially in adult, it is 1.9%. In adolescents, it is 2.2%. In student population, 3.3%. That means, based upon the population you are studying, the prevalence varied somewhere around 1.9 to 3.3%. However, if the same study is conducted in psychiatric inpatient facility, the prevalence went up to 7.4%, both in adult and adolescent. In adult psychiatric outpatient, the prevalence varied up to 5.8%. So, my dear friend, the prevalence of BDD is earlier thought that it is very, very less. And various epidemiological catchment area studies did not even assess BDD. But if you use BDD exclusive scale, you can find the prevalence is very, very high. It starts somewhere around 1.9%, and depending upon the population studied, it may go up to 7.5%. Further, if the BDD is studied in various other special settings, such as in the OPD of cosmetic surgery, OPD, it was found to be 13%. In ENT and rhinoplasty surgeries, it was found 20%. In orthodontic surgery, it was found to be 11%. Cosmetic dentistry, it was 5%. Dermatology outpatient, it was 11%. Acne dermatology, 11%. And cosmetic dermatology, 9%. That means, my dear friend, BDD is very, very common. And in general population, it is 2%. And based upon the clinical setting, if you are studying, it varies up to 20%. Let's look into the BDD and comorbidity. Does body dysmorphic disorder comes alone, or will it come with other friends? Of course, there is a high rates of comorbidity such as depression. Studies have indicated the depression is around 50 to 70%. Social phobia up to 20%. Patient with BDD also has found to have OCD, panic disorder, generalized anxiety disorder, substance use and dependence disorder, suicide, suicidal attempt, suicidal thoughts are very common. Personality disorder in BDD will come as a challenge for any psychiatrist or any physician. Let's look into the BDD and suicide. As I mentioned earlier, the suicidal thoughts, suicidal attempts, and completed suicide is very common in BDD. Studies have showed suicidal ideations are common up to 20 to 30% of the patient who is having BDD, whereas who do not have BDD, it is only 3%. If you look at the attempted suicide, 7 to 22% of the BDD patient had attempted suicide in the recent past, compared to 1 to 2% without BDD. There was a long-term study up to 4 years It was followed up the 185 patients suffering from BDD. And in that study, they found 45 times higher of suicide than compared to general population. That means suicide is very, very common in BDD population when compared to either depression or eating disorder or psychosis. In psychosis and bipolar disorder, it is 10%, whereas in BDD, it is 45%, my dear friend. Let's look into the BDD and how does it occur and why does it occur. There was a recent meta-analysis done by Cook et al. They looked into the self-esteem and BDD. There were 25 studies which were taken and considered for the meta-analysis, which included 6,278 participants. This study clearly said that self-esteem plays a very crucial role in BDD. Let's understand how did they define self-esteem. Self-esteem is one's positive or negative attitude towards the self. That means what is your attitude towards yourself with regard to your looks, with regard to your performance, with regard to your functioning. That means one's positive or negative attitude towards the self. This study, Cook et al. Clearly said that it demonstrated the low self-esteem is an important hallmark of BDD, and it goes beyond the depressive symptoms. Even if they control for depression, self-esteem continues to remain significant in BDD patient. It appears that negative evaluation of the appearance in BDD goes beyond self-esteem, and the self-esteem is not only just because of appearance, the self-esteem also with regard to overall personality and extends to the whole domain of self here. That means it is not just the perceived flaw. In BDD, the patient also will have perceived personality flaw also. Let's understand the neurobiology of BDD. There has been various studies which looked into the neurobiology of BDD. One of them is neuroimaging studies. Various neuroimaging studies looked into the brain architecture and what are the defects seen. Some of the reports which clearly reported that abnormal structure and functioning of the occipitotemporal and frontolimbic region have been implicated. Further, some studies have said that cortical gray matter thinning seen in the left temporal and left inferior parietal region, hypoactive connectivity, and poor information transfer between the primary and secondary occipital region. Connection between the insula and the central occiopercular cortex was found to be reduced. Increase in total white matter volume and caudate volume asymmetry was noted in BDD patient. Further, one need to understand the involvement is invariably on the left side, involving occipital, temporal, and parietal region. Here, the BDD patient interpret visual information that is holistic in nature via the neural pathway meant for detailed focused information. That means there is some abnormal activation of the pathway. Here, the patient who are supposed to look at the holistic facial recognition, they are focusing on minor details and minor flaws, and they get preoccupied with that. Further, the BDD patient experience deficit in the interpretation of facial emotional expression, particularly as they regulate anger and disgust. The neuropsych assessment is very clear about this. They are also hypervigilant, and also heightened social sensitivity and rejection is seen. And they focus more on the minor details, both in the surrounding and also in their facial expression or facial features. The neurobiology has been implicated with regard to combination of biological, psychological, and environmental factors. There has been a phenomena which has been considered as the patients with BDD have been experiencing abuse in the childhood, exposed to violence and trauma, but that doesn't alone will explain BDD. There is a need for the predisposition and precipitating factor and further leading to BDD. But however, at this point of time, we know there are some changes in the brain, but we do not know the exact nature of the change. The neurobiology is evolving. At this point of time, we do not know the exact cause of BDD and what are the areas implicated. Although we know there is involvement in left occipital, temporal, and parietal region. Let's look into how to do the assessment of BDD. The BDD can be screened by using a simple instrument, which is BDD questionnaire. These are 4-item scale which can be used in any OPD. The 4 questions can be asked easily within no time. Further, there is one more body dysmorphic disorder diagnostic module is also available, which is a 6-item scale. To use this 6-item scale, the physician need to undergo training from the person who has undergone training. Let's understand the neurobiology of BDD. What causes BDD? The first and the foremost, the neuroimaging studies have clearly indicated some changes which are occurring in the brain. There are some structures which have been indicated, such as occipitotemporal and frontal limbic regions have been implicated. Further, cortical gray matter thinning is being noted in left temporal and left inferior parietal region has been implicated. There has been hypoactive connectivity and poor information transfer between the primary and secondary occipital region have been noted. Further, connection between the insula and the central opercular cortex was found to be reduced. There is increased total white matter volume and caudate volume has been found to be increased in BDD patient. But BDD patient interpret visual information that is holistic in nature via the neural pathway meant for detailed and focused information. That means neuropsych assessment clearly indicated BDD patient experienced deficit in the interpretation of facial emotional expression, particularly as they relate anger and disgust together. They are hypervigilant, heightened social rejection, and also sensitivity to criticism. They focus on the minor details rather holistically looking at the face. That means there are some brain regions which are responsible for looking at the minor flaws or the defect which are noted in them. However, the neurobiology also indicates the combination of biological, psychological, and environmental factor. Just only looking at the environmental factors, childhood trauma, sexual abuse cannot explain BDD alone. But however, they may act as a precipitating factor. There is a need for predisposing factor, that is genetic factor, to develop BDD. At this point of time, we do not know the exact cause of BDD. But however, the preliminary investigation and research indicates that there is a problem in the brain. Let's understand how to do BDD assessment. The BDD assessment can be done very easily by using a screening instrument, that is BDD questionnaire, which is 4 items questionnaire which can be used in any OPD setting. And this is a self-administered question. If the patient says yes to one of the items, then they need to meet the psychiatrist. The second important tool is BDD diagnostic module. This is a 16-item module which is administered by the physician. The physician who is going to administer the 6 items need to undergo training in administering this instrument. One of the commonest simple questions which can be asked by the physician is, in the OPD, is, are you concerned about your appearance in any way? Are you unhappy the way you look? Does this preoccupation takes a lot of time? How much time do you spend thinking about your body area of concern or the defect that you think? What effect has it have on your life with regard to preoccupation about this defect? Is it affecting social life, family life, academic life, or occupational life? And finally, you can ask, on an average in a day, how much time do you spend thinking about this? It may be less than 1 hour, 1 to 3 hours, or more than 3 hours. These are the simple 4 questions which can be asked to any patients. However, please remember, BDD is very commonest, very frequently occurring, prevalent illness, but unfortunately, it is not diagnosed. The patient think that they are having a defect and they are born defective and it needs correction, and the family members also do not perceive as an illness. And even the healthcare professionals are not aware of body dysmorphic disorder. Hence, all health professionals need to know about BDD and need to screen the patient whenever they touch base these patients. What are the treatment of BDD? There are three important treatment. One is surgical intervention, medications, and therapy. What is this surgical intervention? Of course, the BDD patients have flawed defect. They feel their nose is crooked, their chin is crooked, their eyes are not symmetrical. They would like to undergo surgical intervention. There are studies which looked into the surgical intervention in BDD. And unfortunately, the surgical intervention has not found to be helpful. The studies have clearly said that precious health resources have been wasted in treating BDD with surgical intervention. And these surgical interventions are targeted to fix the imaginary flaw or else to fix the perceived flaw. Hence, even after fixing, the patient do not get satisfied with their surgical intervention. Studies indicate that surgical treatment is not effective and can lead to patient feeling that they have become worst. That means imagined defect has worsened further. BDD experts clearly advise against surgical intervention. They say no for any cosmetic intervention. If the patient insists for surgery, request them to delay and to undergo treatment in BDD. If the patients undergo surgery, invariably the perceived flaw will increase. And further, the patient becomes unhappy and they may become litigious. They may go to any extent to sue the doctor for perceived flaw. And there are many patients who have undergone multiple cosmetic surgery to overcome this perceived flaw. Hence, it is very important for the dermatologist and also the plastic surgeon to do the screening of BDD. Not only that, one need to be aware of BDD and refer them to psychiatrist. And the studies have clearly said that surgical intervention in BDD is helpful only in 10% of the patient. 75% of the patient have said no improvement. And in 15%, they reported there is worsening of symptoms in BDD. Let's discuss about the medication in BDD. There was a recent review by Hong et al. In 2019. The title of the study was Pharmacological Treatment of BDD. This study clearly said that SSRIs are the first line of treatment. Most of the studies which are available with regard to BDD are open label trial, and hardly 3 to 4 RCTs are available. With regard to medication, as I mentioned, serotonin reuptake inhibitors are the first line of treatment, such as fluoxetine, sertraline, escitalopram, citalopram, paroxetine, and fluoxamine. Clomipramine as a tricyclic antidepressant has also been tried. Here, the dosage of medication is very high, similar to OCD. The patients will not respond for antidepressant dosage. If you are giving fluoxetine, you need to give in the dosage of 60 to 80 mg. If you are giving sertraline, it should be between 200 to 300 mg. Escitalopram between 30 to 40 mg. Citalopram from between 60 to 80 mg. Paroxetine 50 to 75 mg. Fluoxamine 200 to 300 mg. That means the dosage requirement is very high. Again, the duration, at least 2 to 3 months in adequate dosage should be given before telling that this medication has failed. That means in BDD, the depressive dosage will not work. It is the OCD dosage and duration need to be tried in BDD. The role of antipsychotics is not clear. But however, various open label trial and also the case series have reported antipsychotics have been useful in patients with BDD with the delusional level of insight. That means they have a poor insight and delusion of body dysmorphia is noted. In such cases, risperidone, quetiapine have also been tried. To know the progress of treatment, we need to use modified Vibox BDD scales are available. This modified BDD Vibox scale is a 12-item scale which rates the severity, and this will be helpful to know the progress of the disease and also response to the treatment. Hence, my dear friend, the treatment in BDD is similar to OCD. Sohang et al. Also gave the chart. The first line of treatment is SSRI. After giving adequate dosage and duration of 2 to 3 months, if there is no improvement, switch to the second SSRI, or else use augmenting strategy such as clomipramine. Antipsychotics can be tried. If there is no improvement further, combination of 2 SSRIs, SSRI and clomipramine can be tried. Further, you can also consider combination of medication with cognitive behavioral therapy. But however, how to choose medication in BDD? The medications are chosen based upon the comorbidity, side effect profile, and the patient's comfort with regard to certain medications. The comorbidity, if there is a depression or else suicidal ideas, ECT can be chosen along with the medication. If the patient has severe depression, SSRI plus ECT can be considered. If the patient has anxiety symptoms, SRI and benzodiazepine such as clonazepam can be considered. If the patient has personality disorder, then medication plus therapy will be the choice. If the patient has very poor insight or delusional level of insight, in such a case, antipsychotic plus SRIs can be considered. Hence, my dear friend, the medication is based upon the side effect profile, patient's comorbidity, and the patient choice. Let's look into the CBT in BDD, that is cognitive behavioral therapy in body dysmorphic disorder. Evidence have clearly indicated there are 6 RCTs are available with regard to BDD and CBT, especially in adolescent and adult. They clearly indicated that response rate of up to 50 to 80% have been seen in CBT. The CBT used in BDD is similar to OCD. Up to 16 to 20 sessions are required over a period of 3 to 6 months in BDD. Each session lasts for 60 to 90 minutes and 1 to 2 sessions per week. And insight plays a crucial role in cognitive behavioral therapy. Sometimes the patient may require 3 to 5 booster sessions after termination of the sessions. When the session starts, the session should start with the baseline assessment. At the same time, you need to have clear goal setting has to be done. The role of therapist, the role of client need to be clearly understood and documented. Psychoeducation should occur parallelly. At the same time, patient should understand why there is a CBT is required. If the patient has fair insight or a good insight, it is easy to consider them under CBT. If the patient is having a poor insight and shows resistance for therapy, it is useless to do therapy in them. However, you can try motivational interviewing. Cognitive therapy can be also tried. If the patient does not cooperate with therapy, then the therapy becomes futile. If the patient responds and keen on continuing therapy, please ask them to keep a diary. This is thought diary has to be kept. The thoughts which triggers with regard to BDD needs to be documented. Hierarchy of these cues need to be kept. And once you understand these thoughts are coming and what are those thoughts, what are the perceived flaw which the patient is concerned about, please empathize with them. Do not challenge these perceived flaw in the early part of the therapy. Once you are able to build the rapport, once you are able to empathize with the patient really feels, yes, this doctor or the therapist is able to understand, then you need to do cognitive restructuring. The cognitives, we need to understand them, such as the patient may think he looks like a monster because of the crooked nose. That is catastrophization. overestimating the meaning and importance of perceived flaw or imperfection, that is selective abstraction and maximization. I have to be perfect, all or none phenomena. If I have a flaw, that means I'll be rejected. Everyone is looking at me. Everybody is talking about me. Everyone is discussing about my flaw. Is mind reading. Sometimes automatic negative thoughts come in the way. Since I am having a perceived flaw, nobody loves me. Everybody hates me. Everyone rejects me. There is no point in living. Hence suicidal attempts or suicidal thoughts. Once you are able to know the cognitive profile, then if the patient is ready, you need to do exposure and prevention of rituals. Here, once you know the cues, systematic desensitization can be attempted, but however, many therapists believe in flooding. Many of them even consider hierarchy of these cues and also to expose them and to prevent the rituals of looking into the mirror, checking them, or trying to do self-surgery on these perceived flaw or applying cosmetics, camouflaging need to be avoided. Homework assignments such as going out, meeting people, going to public places, attending meetings to be done. And also you need to do cognitive re-challenging at this point of time, asking for evidence, and also need to challenge their belief system. At the same time, you need to use cognitive strategies to enhance self-acceptance, self-esteem, and self-compassion should be done. At the same time, you need to discuss about the weaning of these sessions, and relapse prevention has to be done and booster session to be done. What are the predictors of CBT which have a good outcome? Studies have clearly said that readiness or motivation for therapy plays an important role. Insight into the illness, baseline severity, homework compliance for cognitive behavioral therapy, and treatment expectancy have been found to be a good predictors of BDT. If the patient has depression or else substance use, they have not found to be a predictor of good outcome. However, these are the points which have been found to be having a good predictor for CBT in BDD patients. What is the very important step? BDD awareness has to be done. There should be a massive community awareness program for public with regard to BDD. And also healthcare professionals also should know about body dysmorphic disorder. To counter the false advertisement and claims, fairness screams, these need to be removed from the advertising agencies. At the same time, these advertisements should be banned. Screening of patients undergoing cosmetic surgery should be done so that you are able to find those BDD patients, and doing surgery is not helpful. Hence, they need to be subjected to cognitive behavioral therapy and medication. Further, in children, self-esteem building exercise need to be done as a part of life skills program. To conclude, my dear friends, BDD is very common and very prevalent, but unfortunately it is an hidden epidemic. Hence, there is a direct questioning need to be done by the healthcare professional to ask whether they are concerned about their appearance and looks. People with BDD are often ashamed and they are embarrassed to discuss about their flawed defect or perceived defect. Suicide and attempted suicide is very common in BDD patient. Hence, screening, asking actively about BDD symptoms, early diagnosis and treatment is the only way to go forward. One approach to treating the patient with BDD is to change their appearance, that is surgical intervention. But however, studies have clearly said that surgical intervention is helpful in only 10% of the patient. 75% of the patient who undergo surgery said there is no improvement at all. And in 15% of the patient, there is a worsening of the perceived defect or flaw. Such patients can become litigious. Hence, cosmetic surgeons and dermatologists need to keep aware of this. Hence, they need to do screening all these patients before they go for surgical intervention. Hence, my dear friend, avoid surgeries or postpone the surgeries in BDD patients. And treatment for BDD is the first line of treatment is SSRIs, and the dose and duration is equivalent to OCD dosage, not the antidepressive dosage. CBT plays a crucial treatment in BDD. Combination of treatment, both CBT and medications, plays a crucial role in BDD, my dear friends. However, please remember, BDD is very prevalent, and also attempted suicide, suicidal thoughts and completed suicide is very high in BDD. Thank you very much for giving your valuable time. Stay safe.